Good afternoon, everybody, and good morning to our colleagues in the US. Thank you all for joining in our Pediatric Emergency Medicine lecture series. So we're going to have our lecture series 9 for this month. And it's going to be on a very interesting topic that's going to be looking on pediatric injury prevention at the emergency care setting. We're going to be having two of our presenters. We're going to have Dr. Sofia from Emory University, who is an assistant professor and also a specialist in pediatric injury prevention. We're also going to have Dr. Alphonse Simbila, who is an honorary senior lecturer at MUHAS, who is going to take us through the talk and is also interested and an expert in pediatric injuries. So thank you all for joining in. And just to remind you, we always have this lecture series every month, and they are CPD accredited, where you'll have 3 CPD points. During the sessions, you will all be muted. If you have any question, you want any clarification, you can just put it on the chat. And if there'll be a point where you need to speak, we'll definitely unmute you so that you can join in. Thank you all. Now I'd like to welcome our two presenters to begin the talk. Dr. Sofia and Dr. Alphonse, you are warmly welcome.
Thank you, Dr. Humphrey, and I'm honored to co-host this talk with Dr. Sofia. Can we go to the next slide now? Should we start our talk? So by the end of this talk, we'll have gone through a highlight on the leading causes of pediatric injuries in Tanzania. We'll learn child and caregiver-centered preventive measures. We also identify opportunities for community preventive measures. And we are going to highlight the role of healthcare professionals in injury prevention, education, and advocacy in the end. So, otherwise, injuries in general are a global epidemic. We should be concerned because they're a major cause of premature or untimely and preventable deaths across the world. That's why we have this talk today.
I just lost audio. Just making sure that we can still hear Dr. Simbala.
Can you guys hear me?
Yes.
So I was saying, when you look at this photo, it portrays life. Life is a journey full of events and activities which do not exempt children. So through life, children in Tanzania or in an African context, they are taught or either required to be self-reliant or independent very early in their life. For example, if you look at the top left photo, children travel long, unsupervised distances in unsafe roads, be it when they are sent to fetch something by their parents or to and from school. They engage in normal and abnormal household chores. For example, if you look at the photo down, left down, they spend time at school, the top right photo, for educational purposes. And we tend to think that this environment is supposedly controlled and supervised. Now you will be surprised why we have a photo of a desk down right. The desk at the bottom right corner of this slide reminds me of an 8-year-old child, a female, who I'll name B for privacy purpose, who presented to the emergency department with inability to move all 4 limbs. I was surprised. She reported being pushed from the desktop by her friend while in class playing jumping hurdles. For those coming from Tanzania, you know that when you're in class and you're a child, you want to jump from one place to another like a competitive sport. Now, she suffered a spine injury, from whose complications she died 6 months later. What a tragedy. It's a loss for the family and a loss to the nation. All these scenarios and many more pose injury risks within life's normal routine among children. Next slide, please. So globally, pediatric injuries are listed among the emerging priorities for children's health. They rank among the top 3 causes of death and life-threatening or lifelong disability among children aged especially from 5 to 15 years, with road traffic injuries, drowning, burns, and falls being the commonest causes, as depicted in our slide. Can I move to the next slide, please? So in Tanzania, a recent study by Professor Sawe, one of our own, and his colleagues, revealed that among pediatric injuries, so among injuries, total injuries that they studied, pediatric injuries constituted 25% of all injuries seen at 13 different level health facilities in Tanzania. And falls, road traffic crashes, and burns were the topmost causes of injuries among these children. Next, please. So looking at the road traffic injuries among children, studies such as a household survey that was conducted by Akasrek and his colleagues among Tanzanian children and adolescents revealed children being involved in road traffic crashes and injuries at a rate of 27.4 per 1,000 children, which is alarming and which is higher than the average sub-Saharan national rate. This is another reason to embark on preventive measures or talk about preventive measures in Tanzania. This is why, before talking about what the community and authorities can do, we think we should initiate preventive measures at an individual child level. So it is important that we educate children and provide guidance on such measures as how to walk safely along the road, including walking facing the traffics and never give your back to the traffics. For those coming from Tanzania, we know the common phrase that we teach children, uendapo barabarani, pita upande wa kulia. Meaning, when you're going up the road, use the right sidewalk. We drive on the left. So you're supposed to see the traffic coming facing you. The other measure would be teaching them to identify safe and dangerous places to cross the road. So teach them when you want to cross the road, use the zebra crossing if available, or at least pick a spot which is not dangerous. They are to know how to identify blind corners because these are areas that are prone to accidents and hence injuries. In rural communities, children, especially boys, herd or drive big groups of animals, cattle, goats, sheep, and animals of the sort. They're also to be taught how to drive these big groups, especially when they're crossing with the group, like they're going across the roads. We have major roads passing through villages all over Tanzania, and in the same regard, most parts of Africa. I'll talk about the last part. There's an interesting implementation measure which was established by the European Union project called AMEND. This project distributed reflector-enhanced school bags to improve children's visibility as a safety measure when they use the roads. I think this was one among the most creative ways and effective ways to prevent children injuries as far as the road traffic injuries are concerned. Can we move to the next? Now, it is true that transportation of school children may be a challenge and probably expensive, but the community has a role to play as far as preventing road traffic injuries is concerned. What you see in the picture is a common phenomenon among the urban dwellers called the mshkaki transportation. As you can see from the photo, you have a driver that has a reflector and has a helmet, but the children are not protected whatsoever. Look at the last child hanging. There is no backrest or anything that supports her or him. This is very dangerous, but it is a phenomenon among Tanzanians and people from the same context. Next slide, please. So as a community, we are supposed to enforce child-appropriate traffic and motor vehicle rules as a preventive measure. I can highlight a few of them here. Though the list may not be exhaustive, I'll still go through it. For example, let us describe the Mshikaki way of transporting children. It is not safe. I wouldn't want my children to be transported in a similar way or in that fashion. Let us also encourage and educate the community on the use of child-appropriate seats and seat belts. And this is in both private and public cars and buses, especially school buses, if we are to combat this problem. We can have designated adults to help children cross the roads safely, especially in concentrated areas, children-concentrated areas like school areas. I have seen this being done in some parts of Tanzania, which is something to be commended. There's also an area of improvement as in proper installation of road safety signs and teach the children how to use them. Not only that, when we're building our roads, there's a room or there's an opportunity to create footpaths that are safe on either sides of the road, which will also be one of the preventive measures that can lower these things. Next slide, please. Now, how about bounds? In the same study by Professor Sao, it was seen that 16% of the children that were studied suffered burn injuries, and they were between the ages of 0 to 4 years, very tender age. Next slide, please. So in discussing preventive measures, we are going to divide the burns into scalds and ponted burns. Now, starting with the scalds, there are some recommendations to caregivers. The caregivers are recommended to, 1, keep hot liquids out of reach of the children. That is, you can keep them on high counters or at least at the center of the table where the toddlers or children cannot reach. This is a simple and very easy to execute preventive measure. The next thing that can be done is you are not to put liquids on tablecloths. Children are inquisitive. They tend to pull clothes, and as a result, these hot liquids spill over to them and they get burnt. The next measure can be when you're feeding the children, when you're preparing feeds or food for children, at least have some time to test the temperature of the food before you give it to the child. It may be too hot for them not to be burnt. I know in cold areas in Tanzania, like Iringa, Njombe, Arusha, and areas of the like, with the cold weather, we are sometimes required to warm our bathing water. So before bathing the children, have some time to test the temperature if it's right, and it will never burn the child. These are very simple measures. The other thing, this is to all of us, but especially our African mothers, never hold an infant while holding hot liquids or foods. I know you can multitask, but this poses a risk too. So don't do that. Next slide, please. Now, additional measures or recommendations on scalds include turning pots and handles towards the back of the stove and never leave food cooking on a stove unattended. You know, when a pot handle is facing the child, they are either tempted to touch it or they can accidentally knock it and hot things spill over to them and they get burnt. Another recommendation is keeping cooking utensils out of children's reach. I know this is difficult, but it's among the measures. Children are always all over the place. So bottom line, we need to be vigilant. You're also recommended to keep your children out of the active areas of cooking. Now, in Tanzania, most of the houses have kitchens outside. So keeping out the children from the active areas of cooking could be closing the doors of the kitchens and never let them get into them easily. So do not allow your children to cook without supervision. We know for old enough children, you may be tempted to leave them to cook, but please don't leave them unsupervised. Next slide, please. Now, as far as contact burns are concerned, we can prevent them by, one, discouraging, again, holding infants while cooking, just like in Scouts. You can also keep children out of the kitchen, as I had already said, or don't leave food on the stove unattended. And in this regard is hot food. We have appliances, both electrical or from a Tanzanian side, we have the famous charcoal iron device. So keep these electrical appliances out of reach of your child and unplug them when necessary. Or extinguish the fire once you're done with using the charcoal iron, as it's accustomed to us. You're also required to keep your child away from the fireplaces. For those using wood outside the houses, put the fire off. You know, you may be tempted to say, I'm done cooking and I can just leave the fire and go out by itself. Children are inquisitive and they can go play around it, they can step on it and get burnt very easily. So keep your child away from the mufflers as well. For those using the motorcycles, as I said, as a transportation measure for children, for school purposes and for private purposes, but also cars. Can we go to the next slide? Finally, before I hand the talk to Dr. Sofia, I would like to talk about falls and play-related injuries. Now, a child's developmental stage, level of activity, and the environment associated with the stage have a bearing on both the incidences and characteristics of either fall or play-related injuries that they may be involved in, as we see on the picture. Now, prevention-wise, in order to ensure safety in both indoor and outdoor playgrounds, I think we should encourage constant adult supervision. Now here, I'll be very careful to talk about the commercially promoted mushrooming of play areas and playgrounds, especially along bars and hotels in Tanzania. When we talk of constant adult supervision, we mean an adult who is not taking alcohol, an adult who is not partying and forgetting about children. I know we go to these places to have fun and enjoy ourselves, but children are part of our life. We don't want to be disturbed and taken unaware by children injuries. So another measure that needs to be encouraged is the appropriate home engineering, including things like installing age-appropriate impact-absorbing surfaces or age-appropriate room designing. I know this may be all ambitious to most of the Tanzanian friends or colleagues, but it's an area that needs to be taken into account. The other thing is observing playground safety solutions, especially for these commercially made areas, because the public ones may not be highly sophisticated. So by equipment safety solutions, we're talking about things like lowering the height of things like the monkey bars or the equipment that the children hang on to a height of around 1.5 meters, which could reduce the risk and severity of injuries. Or you may be needed to install appropriate and sufficiently thick surfaces. As I said, the impact absorbing surfaces or materials. But also put adequate handrails and guardrails for children to play. But in Tanzania, if you look at the top right corner, there are very inexpensive measures. For example, setting play areas for children that can also be supervised by the adults. But if you're capable, down the bottom photo shows a playground which has safety measures as guardrails and the handrails. But if you look at the surface, like the carpet also, it looks like it can absorb impact and it's soft enough not to cause injuries to the children. So with that being said, I'll now take a break and invite Dr. Sofia to continue with the talk. Welcome, Dr. Sofia.
Thank you so much. So I'm going to touch on 2 additional injury mechanisms and then sort of leave us with some opportunities for prevention and interventions moving forward. So one of the other major injury areas that we're seeing in the Tanzanian population is specifically drowning. And this report is from a study done by Dr. Saraseth and his colleagues. And it matches one of the prior WHO reports. So similar data trends that was seen previously. But drowning, essentially, we know that there are about 5.1 drowning deaths per 100,000 persons per year. And there are particular high-risk populations, so males more often than females. In the pediatric age group, children under age 1 and 1 through 4 had the highest peaks. And then after that, older adults. And that's partly had to do due to their profession. And that's sort of why we see that shift into adulthood. There is significant geographic variation, and really across the country, really depending upon where the nearest body of water is. But there's also differences based on rural versus urban. So in rural areas, you tend to have more drownings around open bodies of water. So things like ponds, rivers, lakes, lots of drownings around Lake Victoria, including most commonly the fishing community. In particular, the fishing communities are at higher risk, often due to things like lack of awareness of water safety, poor access to affordable and effective personal flotation devices. The vessel itself may not be seaworthy. They may not know how to swim, and they may have poor access or use of appropriate weather information that can really guide whether or not they're going to get on that boat that day. Additionally, there may be issues with navigational equipment and then delays in sort of emergency response measures, which can increase morbidity and mortality. We are also outside of, the risks with open bodies of water in rural areas, seeing more drownings in the urban areas because of the building and presence of more pools. And so we'll talk about ways that we can sort of prevent drowning in both of these areas next. So when we talk about drowning prevention in the US, I'm going to sort of share what we typically do, and I think it's very applicable to the population in Tanzania as well. We think about drowning prevention and wanting to do really multiple layers of protection. So it's really just not one thing, right, that will prevent the drowning. Adding these layers sort of guarantee reducing that risk of drowning. And in particular, there are 2 types of layers of protection that I typically counsel families on. So one is protection for when kids are not supposed to be in and around the water. So you want to think about barriers for preventing entrance. And then 2, layers of protection for when they are supposed to be in the water. So when they're actively swimming, what are the ways that we can keep them safe in the water, or when they're actively bathing? So starting with barriers, we have seen that four-sided pool fencing, so basically building a barrier around the pool that separates the pool from the yard or from the house or from the hotel or the building structure has been fairly effective in reducing drowning in young children that are in and around pools by about 50%. And these particular fences, there are measures that are like sort of gold standards that are known to be effective. So things like having a self-closing, self-latching gate, making sure the height is like at least 4 feet tall, and then separating the pool from the house and the yard. So these are things that we can advocate for, as healthcare providers, community members, parents even, as pools may be going up in and around your areas. Outside of that, really other top evidence-based recommendations for drowning prevention, and these are sort of measures of when kids and teens are going to be in and around the water. Everyone on a boat or a water vessel should be wearing a life jacket. Life jackets especially should be worn by young children or non-swimmers that are, even sort of walking, around the water if they don't know how to swim. There's not really there are a variety of devices that are out there that are not necessarily effective. So I'm not sure if y'all have these specific types of floating devices in Tanzania, but in the US they're very popular having these sort of armbands or like neck ring floaties. We don't recommend those because they actually can often deflate. And so they're not that effective. And so over that, we would recommend, wearing a life jacket. The other thing that we recommend is swim lessons. And typically you want to start these, if possible, after age 1. Depending upon the child's individual circumstances, usually lessons are known to lower drowning rates for that high risk group, children's 1 through 4. And you want these lessons to teach water survival skills, so being able to swim with clothes on. Not only, how to just learning sort of the motions of how to swim, but how to like deal with these emergency situations. Also how to wear a life jacket. Children should also be taught to never swim alone. Parents should know how to swim, and also know CPR. When children are in and around water, we recommend just sort of like our other injury prevention, injury mechanisms, constant supervision. And that really can vary by age. So generally speaking, a younger child, you never want to leave around water alone. Parents should be within arm's reach for the younger child if they don't know how to swim or if they're not a great swimmer. Otherwise, within eyes reach, if they are like a good swimmer, like an older teen that knows how to swim, but you need to still have eyes on them. We also recommend something that's called a water watcher. So if you're at, for example, a party or a gathering and there's a pool or kids are swimming in a nearby body of water, that there is at least one adult that's keeping an eye on them, that they're not distracted by their phone, that they're not drinking alcohol, that they are the designated water watcher and that they are competent in CPR. And then, those can be done in shifts, so you then switch off to the next person. For open bodies of water, if possible, swimming in areas where there is a designated lifeguard, if that's possible. Also having some knowledge on, weather conditions that may make it more challenging to swim. It's also important to remember that, if lifeguards are available, that they really only offer one layer of protection. That us as sort of, parents and caregivers, and I say as I have 3 young children of my own, and so we are very much in the learning how to swim phase. But generally speaking, adults and caregivers are the best sort of layer of protection and really the best lifeguard. So when we're looking at swim lessons, some of the things that we recommend is not only learning how to develop basic swim skills, but also really knowing how to be water competent. And that in particular consists of three parts. So specifically, we want kids to have basic swim skills. So they should know how to enter, exit the water, surface, turn around, float, tread, and propel at least 25 yards. Outside of that, the other two components of water competency include having water safety awareness. So this basically includes children knowing their limitations, making sure that they know how to be aware of hazards and knowing how to wear a life jacket. And lastly, the last component of water competency is being able to recognize and respond to other swimmers that are in distress. So those are all really things that we recommend should be incorporated in sort of the swim lesson. So not only basic swim skills, but really water survival skills. So in terms of prevention and really sort of life-saving measures in a drowning incident, we think about something called this drowning chain of survival. This is a concept that has been introduced in the US, and I do think that parts of this, are relevant for our population here in Tanzania as well. Before I talk about this, just one of the big things that I just want to bring up is that drowning is often silent. It is silent. And it happens in a matter of seconds, and that's often why it's really challenging to pick up. But it may be hard to tell that somebody's actively drowning. They may just be sort of bobbing kind of in the water. And that's often why it is really important to have somebody that's watching when kids are in the water and also just being aware of how to look for signs of distress. So this particular diagram illustrates something that's called a drowning chain of survival. And it really defines a series of steps that can be intervened on at any point to reduce drowning mortality, starting with prevention to all the way to providing care after rescue if needed. With really sort of prevention being the most critical step, right? Sort of doing some of those layers of protection that we just talked about in order to sort of avoid the drowning outcome altogether. Early initiation of bystander CPR is associated with the best prognosis and survival. And so that is something that if you're, going to have at least a pool in your community or nearby a body of water, we recommend that, CPR be taught to really even as young as teenage years up through adulthood. And knowing that, hands on the chest early on can be the most significant life-saving measure. I think one of the challenges, obviously, is that, often we say in the US, you're doing this until you get access to the emergency medical response system or the ambulance arrives, and that, may be varied in Tanzania in terms of how children are being transported to the nearest hospital and how far that distance is. But just to sort of put things in perspective, why CPR, is important. We know that there is a poor prognosis with drowning based on the duration of submersion. So children that are submerged greater than 5 minutes have a poor outcome. We know that the time to basic life support being greater than 10 minutes is also associated with a poor prognosis, which is why starting sort of bystander CPR can be really life-saving. We also know that if a child is resuscitated more than 25 minutes for drowning, that is associated with a poor prognosis. Older children have a poorer outcome if their initial mental status or the scale of like the Glasgow Coma scale, which sort of talks about their level of alertness, their motor capability, their verbal capability, if that's less than 5, with normal being 15, that's associated with a poor prognosis. And so thinking just really about, what are opportunities for introducing community programming to really teach CPR to adults and to older teens. So moving on to our last injury mechanism, it was really hard to get consistent data on this particular injury mechanism, but we know that it's prevalent because of the cases of aspiration pneumonia that are seen as the outcome of sort of second outcome due to aspiration of either a food or a non-food foreign body. And here on the photo, you see sort of the most common offenders, things like peanuts, bottle caps, and coins. In terms of prevention for choking, we recommend the importance of, as a reminder to all of us as healthcare providers, to raise awareness of the risks of choking amongst parents and caregivers. So really sort of pointing this out, and things that you would tell the families are that making sure that they remember to cut foods in small pieces, things like grapes and carrots that are easily choked upon, and then really avoiding high risk foods. So ground nuts, cashew nuts, popcorn in the younger age group. Um, Also thinking about how families should recognize that it may not really always be food that a child can choke from, small items like bottle caps and coins, and that older siblings can be problematic. They will try to test and see if their younger sibling will eat things, including small toys, and small parts of those toys. And so they at times can inadvertently pose a risk to their younger sibling in the home. And then lastly, widespread CPR education and choking first aid is critical for really anyone that cares for children. So, in childcare facilities, daycare facilities, caregivers at home, in the school system as well. So we talked about a variety of injury mechanisms. I wanted to take just a few minutes to talk about how to approach injuries in terms of thinking about prevention. And I want to just introduce two frameworks that are heavily used in the injury prevention arena, to sort of help guide communities in thinking about possible solutions. So one of the traditional matrices, or sort of grids, that we think about with injury mechanisms is something called the Haddon's matrix. And this is really a framework for understanding and preventing injuries and public health emergencies by really systematically examining contributing factors before, during, and after the event across really different components. So if you see this sort of chart here on the screen, I'm just giving an example for pedestrian injuries, or road traffic crashes, since that's one of the more common injuries in Tanzania. But you'll see the rows are really sort of the timing around the event. So before the crash, during the crash or accident, and then after the crash or post. And then really sort of the contributing factors in the columns on the top are things like the human factor, so the pedestrian, the child themselves, the agent, and then the physical and social environment. What are the factors related to that? Ultimately, looking at this sort of in these sort of three time points across these three modifiable factors, or contributing factors, can really lead an opportunity to identify solutions. So just sort of talking through a little bit about this chart. So for example, in the pre-event phase, what are some of the factors related to the child? Some of the things that were talked about previously, child development, judgment, they may be, not as tall, hard to see by a nearby driver, lack of adult supervision, and not really awareness of traffic rules, and sort of appropriate crossing of street. When we look sort of at the vehicle, there may be, sort of use of unregulated motorcycles. There may also be issues with the car itself that could be improved upon. And then thinking about the physical and social environments, many of these were mentioned. So things like blind corners, no barriers, mixed land use, so multiple sort of things on the same street close together, like school shops and homes really close to the road. And then thinking about the event itself, right? And like what things could have been done to sort of prevent injury. So, the use of reflective gear for the vehicle itself, making sure that they slow down around the intersection, making sure that they're, focused on like car development that like helps sort of reduce the impact of the crash. And then just thinking about the physical and social environment. So, during the event, There may not be, refuge islands or raised crosswalks where somebody can step aside out of the way of a car. And then post-event, you can sort of see the things listed here, but basically, may not have knowledge of CPR or first responder training for the individuals responding to the pedestrian getting hit, lack of emergency medical systems, or there may be like a delay in getting emergency medical vehicles to the location of the crash. And then just thinking about the physical and social environment after the event. Whether or not there is sort of a robust data collection system that can gather this data about these incidents of crashes so that we can come up with community-driven and appropriate solutions based on locally what's happening. And so looking at this, right, and having this conversation of breaking down these injuries by event, post-event across these modifying factors, you can come up with a lot of these solutions. And many of these were mentioned previously. And so pre-crash, right, the education for the child and the adult about safe crossing, enforcement of helmets and speeding laws, also enforcement of speed limits, right, in school zones, especially. Improvements with sort of just the road itself, infrastructure improvements, community engagement, so involving cross guards, family, like family members, that can be assistance to help with crossing. And then specifically during the event on the top right, are there vehicle improvements that could be introduced, such as better lights, braking systems, street lighting, clearing roadside clutter so you have more visibility of children crossing. And then post-crash, really talking about resuscitative measures that could be introduced and taught, and then sort of just changes to the current emergency medical system, and then improving opportunities for data collection. So this is really the traditional model. And I would argue that it is sort of too, like it's sort of like sort of two different, sort of two-dimensional in terms of thinking about, the timing of the event and then sort of the modifying factors, right, across the grid on the top. And really, we are moving towards, in the injury prevention world, thinking about equity and opportunities for introducing cultural and social factors and sort of structural factors into the injury prevention matrix of how we really approach injuries. And so recently, Dr. Sadiqa Kendi and one of her colleagues, Dr. Macy, introduced a modification for this Haddon's matrix that we have been using for years, something called the Injury Equity Framework. You can scan that QR code to learn a bit more about this particular framework that was introduced, but I'll talk a little bit about it now. One of the things that we noticed, in the US is that children are in the US die from injury at drastically unequal rates. That there are structural factors such as systemic racism, cultural factors. There are, barriers to access to care, barriers to sort of understanding the system of being in the United States, that can impact groups of children being injured at differing rates. There's also the concept of classism, and sort of different parts of society being impacted differently. And so wanting to think really more about injury prevention in this sort of holistic way, this injury equity framework was introduced recently in the injury prevention field. And so when we look at the injury equity framework, one of the big things that it does is that it recognizes that injuries are influenced not only by individual or medical factors, right? So we're not going to be just, we don't want to blame that child, right? That's the pedestrian. We want to think about the broader social and systemic conditions that we as a society, as a community, as healthcare workers, can work with in the systems, along with local government, along with parent and child representatives, along with school representatives, along with like law representatives to sort of come up with solutions together. And this particular framework, it really integrates different aspects that should be considered. So structural determinants such as policies, whether or not there's issues sort of with poverty, discussion around urban planning, previous sort of legacies, colonial legacies, which is something that we get impacted with in the US as well. And then sort of social determinants. So race, class, gender, and age, and how that impacts the injury. Thinking about agency and power and whose voices should be part, who shape injury prevention and who should be added to that table, right? So who's currently coming up with these solutions, but who should be also included. And then really thinking about also institutional responses. So involving healthcare, law enforcement, school-based agencies. And it really sort of highlights how, the differences in access and infrastructure and resources can really shape both the risk of the injury and the ability to recover. And so that's something that we want to include as we are thinking about how to approach one particular injury mechanism and reduce morbidity and mortality for that particular mechanism. So thinking about the Haddon's matrix, right, and that story of road traffic injuries, and when we looked at that prior grid, you can modify that by applying the injury equity framework and coming up with this matrix. And I just sort of filled this in. Ideally, you would come up with sort of this grid or this sort of list of contributing factors and solutions with a series of meetings with different stakeholders. So again, individuals from the community, individuals from the local government, whether that be also including nonprofits that could help with the work, voices of those citizens that are affected by the injury, the school system, law enforcement, and sort of thinking about how to approach injuries with this sort of holistic perspective and well-rounded viewpoint of including all of these stakeholders. And so when we think about the injury equity matrix, some of the big things that you would want to include are, what is the problem? Number one, here on the left, that children have a high rate of road traffic injuries. And then sort of what are the countermeasures, areas where you can potentially, intervene. So what are the contributing factors in the built environment? What are some options for equipment and safety products that could be intervened upon? Where can you provide education and increase knowledge? And then, what are the opportunities for treatment and recovery? And what's different from this to the prior chart that I showed you, the Haddon's matrix, is that you're also including the societal and structural factors as well. But, in particular, you're talking about, are there differences and disparities based on race and class, whether or not immigrant status, which is important for the US, and then, disability. And I highlighted kind of with these contributing factors, where I thought race and class really would be contributing. And then looking sort of towards the right, here are some recommendations, very similar to what was in the prior graph, the prior chart, but it just sort of gives you an idea of how to incorporate the societal factors and also the disparities in this conversation. So thinking about, our key takeaway points, we've talked about a lot in the last 50 minutes. And so just to kind of bring us home, a couple of reminders here. So injuries are common, but there are many measures for prevention. And we've listed some, not necessarily a comprehensive list, but really some that are the most common and the most effective that we have found in our work and sort of in our daily work at the bedside. And then also knowing that healthcare provider awareness of these injury risks provides opportunities for parental education. So we are, can be champions for injury prevention in the care that we provide to children when we see them in the hospital system, But part of that care is also sharing these opportunities for prevention and reminders to families on how they can keep their children safe. And then lastly, there is always room for innovation and improving current preventive measures. We talked a little bit about some things that, we're doing more recently in the injury prevention world, including just like I mentioned, the injury equity, framework and the matrix, and thinking about how to approach injury prevention measures. Also sort of the drowning chain of survival, and where there are opportunities with some of these injury mechanisms. So I wanted to just point out a couple of resources for injury prevention. I'll start with ones that we can do both locally and also globally. So just looking to the right, global injury prevention measures and that you can sort of think about by looking at these injury prevention organizations. They offer a lot of information even just on their website. So Safe Kids Worldwide is an organization that looks at all injury prevention mechanisms and does have a global presence, and they have great educational material and examples of how they have done some community-driven work locally all around the world. The WHO, which I'm sure all of us are familiar with, do a lot of work in this space as well. In particular, one of their branches, a Global Alliance for Care for Injured. That particular branch is a collaborative organization with governmental partners, nonprofit partners, who collaborate really to improve care for the injured across the spectrum of pre-hospital, hospital, and then rehabilitation. So sort of the whole spectrum of injury. And their goal is really to kind of strengthen the trauma systems. Looking here to the left, we have at Emory, so my institution and Dr. Murray's institution, we have the Injury Prevention Research Center, and we offer a lot of webinars and educational sessions on injury prevention sort of data, but also sort of prevention measures and research. And that's something that we can definitely share on how to access some of those lectures, but you can just go to the website. The webinars are often listed there. So it's not only just collaborative groups working on different injury prevention mechanisms, but they also do a lot of education in the center as well. And then Children's Healthcare of Atlanta, the children's hospital that I work at, has amazing, incredible parent-facing handouts on different injury prevention opportunities across mechanisms of injury. And then here locally in Tanzania, we have these national guidelines for the establishment and management of daycare centers. There's also this national road safety policy that was put together by the Ministry of Infrastructure and Development. And then there's national guidelines for the establishment and management of daycare centers that was previously on the other slide. And then Safe Schools Africa. So, lots of resources that are available and accessible to us. And so we wanted to highlight a few that we thought would be helpful. So I'm going to pause there now just for questions. Thank you.
Thank you very much, Dr. Sofia and Dr. Alphonse, for a very enlightening and then eye-opener. It was a very great talk. And I'm sure that all those that have been listening are going to be good ambassadors to the community. So it's now our responsibility for us to go and educate the community on all that we have learned on this great talk. Thank you very much, Dr. Sofia and Dr. Alphonse. So if there's anyone who has any question, you're just allowed to write it on the chat. We still have 6 minutes. And our presenters and will be happy to respond to all the questions that you will have or any concern. Likewise, if you want to speak, you can also unmute your mic and you can also ask your question, or if it's, you want to give an example, a scenario, we still have 5 minutes before we wind up our session. So you're warmly welcome to ask, clarify.
I think it was just a question in the chat if we're going to share the notes. I'll let Dr. Murray answer that.
Okay, so as we have already said, that we'll not be sharing the slides, but all these lectures have been recorded, and we have a YouTube account that has all the recorded PEM lecture series session. And I'll also share again the link with you right now in the chat, so that if you want to access any of the lecture series, you can easily access them from there. So let me just share it on the chat and anybody can access it. Okay, thank you all. Seems like there's no any questions. I'd like to say thank you all that have joined in today, and we welcome you for our next PEM lecture series next month. And as always, we'll keep you posted on our social medias, and also remind you via different groups and send you the information on when to join in and the specific date. And we'll also have another interesting topic on the next PEM lecture series. Thank you very much, and I would like to wish you a good evening for those in Tanzania and a good morning for those in the US.
Thank you very
Thank
much.
you all.
Thank you.